Hello class, this is Mr. Streb, and this week we'll be going over care of the patient with common elimination problems. So we're talking about renal or the kidney. This is a big chapter. It's a lot of chapters as a matter of fact, so there's a lot of reading that's involved here. But you kind of have to have an understanding of what the kidneys are and understand that the kidneys are supplied with a really rich blood supply. They get about 600 to 1300 mLs per minute, and that blood supply to each of the kidneys comes through the renal artery, right? Then that branches off from the abdominal aorta and divides into some progressively smaller arteries. It's when you get into these very small arteries, these arterioles, that start feeding the nephrons directly to form the urine. So you have to think about what the kidney is and why kidney problem exists. It's like anything else in the body. It's a clotting issue. It's a lack of oxygen. You're not perfusing your kidneys correctly because these small arteries start to become, they undergo changes, whether there's arteriosclerosis, atherosclerosis, the hardening of the arteries, there's clots, diabetes messes with the small vasculature systems in the body as well. So this is what we're talking about, and this is why people have kidney problems. The nephron is the functional unit of the kidney, and that's where urine is formed, and it filters waste products and water from the blood. So there are about 1 million nephrons basically in each of the kidneys, and each nephron performs the filtration, makes the urine from the blood, and that's how you end up peeing and get rid of all your waste. So that basic knowledge you have to go back and read yourself. We're not going to cover that here. That is something you have to have an understanding of how the kidneys work. I'm simply going to talk about the diseases and what you as a nurse have to worry about. But it's your responsibility to go back and understand how the kidneys work. You've had pathophysiology, you've had A&P, you've done your LVN course, so this is nothing that's new to you. Make sure you go back and look. Your syllabus says that we're going to cover cystitis and UTI. We're going to go over the incontinence, kidney stones, bladder cancer, pyelonephritis. We're going to talk about polycystic kidney disease, acute glomerulonephritis, nephrosclerosis, some vasculature issues, kidney trauma, BPH, erectile dysfunction, and then a nephrostomy tube will be the last thing that we kind of hit here with this. The first thing we're going to talk about is urinary incontinence. When you think about urinary incontinence, you need to go to your book, and we're going to talk about lifestyle modifications to help reduce incontinence. There are things a doctor can do to do surgeries. They can do injections of Botox into the bladder. There's a lot of stuff that can go on. But you as a nurse, you have to understand that urinary incontinence can happen due to a lot of different reasons. It can be caused by multiple births. It could be caused by surgeries you've had, cancers, things of that nature. But what we're talking about is when somebody has urinary incontinence, what is your job as a nurse? You can look here on the screen. There's a lot going on. We know that the kidneys start to shrink with age, so as we get older, we're going to have a little more urinary incontinence. We're going to have some muscle spasticity issues. We're going to have weakening of the muscles in the sphincters. So all of those combined are going to lead to incontinence, like frequency, urinary retention, things of these natures as well. Your book does a wonderful job. If you go to page 1332, there's a QSIM box that talks about bladder training, and these are some of the things that you're going to want to think about. Go back and, like I said, go back and look at those books. The habit training includes scheduled toileting. This is when it's a type of bladder training that's successful in reducing incontinence in these cognitively impaired patients. So to use habit training, you as a nurse would have to help the patient void very specific times. Usually it's every 2 hours. Every 2 hours. Every 2 hours you're going to avoid. On the even hours, if it's 8 o'clock, 10 o'clock, 12 o'clock, 2 o'clock, it's just something you're going to try to help people do. People who use the restroom every 2 hours are a lot less likely to have incontinence. Make sure they're doing some kind of pelvic floor muscle exercises. Think about your Kegel exercises that we should all do. Men and women can both benefit greatly from Kegel exercises. So these are some things that you should be talking to your patient about. Avoiding certain things, like teach your patients to avoid foods that irritate the bladder, such as caffeine or alcohol. These are all things listed on those pages I talked about there in the book. Go back and figure out what your job as a nurse is. Are you going to do the surgery? The answer is no, but you need to think about what you can do to make your patient less problematic, to decrease the number of incontinence episodes that are happening and just to help them live a more functional life. That's your job there. All right, we'll get into cystitis next. Cystitis is inflammation of the bladder. It can be caused by a lot of things, but it's typically caused by a urinary tract infection. I think most people have heard of a urinary tract infection. They are definitely more prevalent in women versus men. Women have a shorter urethra from the opening of the vagina back up. Your urethra is much shorter, just like in the male, in the penis, from the tip of the penis to where it goes back into the bladder, the urethra is a little bit longer. So less likely for a man to end up with a UTI, whereas a female is more likely to end up with a UTI, or we can call this cystitis as well. So inflammation of the bladder typically starts with a UTI that works its way back up. So this is kind of where we're looking at here. You as a nurse have to kind of be aware of what's going on with the patients. First thing you need to understand are the signs and symptoms. You're going to look for a little bit of urine in the blood probably. It could have a more odoriferous urine, cloudy, dark. It looks like it's got an infection in it, if you will. That's kind of the way I think about a urinary tract infection, cystitis. We're looking at urine that has some like I said, traces of infection in it. Pain above the pubic bone is another common complaint that people have. But these are some of the things that you are going to have to be aware of. Those are the things you have to be aware of in order to, basically help your patient out. So what is your job here? Well, with a UTI, a lot of it's going to be teaching your patient about good hygiene. Talk to them about the things they can do to prevent getting a UTI. Wiping front to back. You want to go from the least dirty to the most dirty. You want to make sure if they're on antibiotics, they're taking those antibiotics to completion. Make sure that they have, there's a whole, in your book, there's a whole page dedicated to this. You can go back and look at kind of what some of the things are. It starts on page 1336 in the book, and it kind of keeps going down on what you can do in different types of urinary tract infections and things of that nature. But there's a best practices for catheter-associated urinary tract infection. You can look at that. But basically, we're talking about good hygiene is what we're trying to do here. So make sure you talk about drinking 2 to 3 liters of fluid daily. That's got to be something you do on the regular. We're talking that's 8 to 12 cups of water, right? About 8 to 12 cups of water a day. Typically sugar-free fluids. We're not trying to do Coca-Colas and things of that nature. It should be something that is more like water than not. But we do say you want to encourage fluid daily, so fluid intakes. So go back and look in the book there. It can give you some good ideas on what you are supposed to do and not supposed to do. Talk about good hygiene before and after sex. You should probably clean before you have intercourse and then as well afterwards. If you're wet, you have wet underwear, you should take those off, especially if you're a female, because they can breed bacteria. So these are the things that you have to focus on. Once again, this is nursing school. You're not going to go in and treat the cystitis or UTI. Your job is going to be understanding what the signs and symptoms look like, understanding elimination patterns, thinking about hygiene patterns that help, either prevent or reduce cystitis. Like I said, liberal amounts of water, 2 to 3 liters a day, can definitely promote good health that way, but it also helps with your bladder health, and it keeps your urine nice and clear, like that light yellow urine daily is what you're trying to strive for, very clear to light yellow. There's just a lot you have to worry about as far as what you can do to help your patients kind of prevent this. When you're in your book and you're looking, make sure you're looking at the nursing patient safety things. Make sure you're looking at the QSIM boxes. Like I said, on page 1340, there's a whole page on preparing for self-management, preventing urinary tract infections. It goes over all of the things here that you would need to know in order to be successful at what you do as a nurse. All right, renal calculi is another issue that patients sometimes face when we start thinking about the renal system itself. I know there's a different name for renal calculi. Kidney stones is another name we use. Urolithiasis is the bigger word that a lot of people struggle with. And yes, just like you, I have to sound it out and pronounce it every time. They're hard words, I get it. We're talking about kidney stones, though, is where we're at the moment. So nursing interventions for kidney stones, if you go back and you look at your book, talks a lot about focusing on pain relief, preventing infection, preventing urinary obstruction. Most patients can expel the stones without any kind of invasive procedures, but size is a big part of that. So usually when they're less than 5 mm's, it's most important factor on whether the stone will pass on its own or not. So that's something that you're going to have to think about as far as helping your patient, educating your patient, helping them understand kind of what's going on, how they're going to get rid of the stone. But really, we're going to focus as a nurse, we're going to focus on pain more than anything, and then that prevention of an infection. So I think one of the main things to think about first is flank pain is usually indicative of some kind of stone, right? It could be a kidney stone, a ureter stone, whatever, but that flank pain, coming from the kidney, that could be very indicative of some kind of stone formation that is in the urinary tract itself. We know that there's a lot of different risk factors for getting stones, and we can talk about those later on as well. But some of the big ones that you need to think about is patients who are diabetics. We know diabetics have a higher occurrence in stones than those without a history of diabetes. We know that when people get kidney stones, we worry about, we often see frequency of urination or some kind of dysuria where they're unable to urinate. Especially as the stone starts to reach the bladder, it can cause some kind of obstruction there, and you might not see, if it's in the bladder, you can see a lot of frequency because of the irritation. As it starts going down the ureter itself, it can get clogged, and that could cause some kind of issue with actually expelling urine. So a lot of stuff to kind of look at here. As you're going back and you're doing your reading, think about what causes this kind of stuff, right? And think about some patient teaching. Think about avoiding dehydration, keeping yourself hydrated. The more fluid you drink, the easier it is going to be to pass that. There's a lot of different stones. We don't really talk about the different stones here itself, but there's something to think about. But like I said, the major symptoms of stones is pain, renal colic, and that flank pain suggests that the stone is usually in the kidney or in the upper ureter. So it kind of gives you an idea of where it's at as well. Lastly, I'd say on that, as far as the medications, your book lists a lot of medications, interventions that you can do, how they could go in and do some, they could break up the kidney stones themselves, like lithotripsy. That's something they could do as well. But your book on page 1346 talks about drug therapy, and it says needed in the first 24 to 36 hours. This is when pain is the most severe, and some kind of opioid analgesic usually can control it. But we usually start with something called a ketorolac. That's the medication of choice that we usually end up giving for kidney stones. It's an NSAID, and it's been very effective. It really helping the patient decrease their pain. All right. The next thing that I have on my list to talk about is, I'm sorry, I kind of got out of order here, is kind of two things. We have bladder cancer or cancer of the urinary system itself. When we talk about this type of cancer, the lining of the transitional cells in the kidney, the renal pelvis, the ureters, the urinary bladder, the urethra, these can all be encompassed underneath this. But the most common occurrence for this type of cancer is in the bladder itself. So we typically go with bladder cancer here is what we're going to talk about. Why do I talk about bladder cancer so much? Well, there's not a lot we're going to do for us, as far as nurses are concerned, but we understand that just like a kidney stone, if you have a ureter that is blocked or something, if you have a bladder cancer and we have to end up removing the bladder, it leaves the patient with the inability to store urine and to urinate like they should. So that kind of brings me into the nephrostomy tube as well. And the nephrostomy tube is a tube that's usually placed into the kidney to drain urine directly from the kidney due to the fact that you don't have a bladder for it to go in there. Like I said, this could also be used for somebody who does have a blockage, but this is what we're talking about. We know often a nephrostomy tube will be left in place after you have a kidney stone, as it helps prevent the stone fragments from passing through the urinary tract and causing more issues. So it's not uncommon for us to see these as nurses. We will be dealing with nephrostomy tubes. We have to monitor our patients for all kinds of complications, but really the complications include bleeding at the site, either through the tube, they could have an infection, even a pneumothorax, and these things do happen. But for us, we're going to monitor the nephrostomy tube drainage for volume and the presence of blood in the urine, right? So the first 24 to 48 hours after tube placement, we'll probably see some drainage and blood, but we shouldn't see a lot afterwards. So for us, if you're thinking about taking care of a patient the first 24 hours post nephrostomy tube placement, we'd be assessing the patient's abdomen for any kind of signs of distension. We'd be looking at vital signs for any kind of signs of hypovolemia, which would lead us to believe there's some kind of bleeding. So tachypnea, tachycardia, hypotension, those are the things we're going to be viewing and looking out for with a patient who is returning with a nephrostomy tube. All right, pyelonephritis, this is the next part we're going to go over, and this is in reference to inflammation of the renal pelvis itself, usually caused by some kind of bacterial infection. Typically, it's going to be E. coli, right? We get E. coli that gets into your renal tract. This usually happens for poor toilet training, like if you use the restroom and you're wiping back to front, so you're pulling fecal matter from your rectum into the vagina area. That can breed and harbor some bacteria that can get into the urethra and work its way up and then make its way up to, basically the kidneys. And that's where we get anywhere up the urinary tract to the bladder and then so forth. So when we think about pyelonephritis, we're just kind of go back to the same thing, thinking about how we as nurses are going to prevent that. And really it goes back to patient teaching once again. Assessment findings, they're a lot like anything else. Flank pain, right? If you get any kind of infection there, you can get flank pain as well. Pain that radiates from the side down to the groin area. You could have urgency, frequency, burning on urination, just things of that nature. So we want to increase the fluid intake, and then we want to make sure that the patient follows up. They have urine cultures to see if there's any other kind of problems that we can treat or deal with. And once again, bacteria, we can treat bacteria with antibiotics. So hopefully, in this case, the patient is prescribed their antibiotics and kind of go from there and eliminate. All right. The next thing we're going to talk about is acute glomerulonephritis. So the nurse is instrumental in basically kind of monitoring the patient, seeing what's going on. You have to understand first that healthy kidneys control urine elimination, right? This is something that just has to come back to you. So when we're thinking about different types of inflammatory processes going on in our patients, think about what the body does, how the body ingests all the sodium and potassium and protein and nitrogen, and it has water coming in. Your cells use that, but then you secrete what you don't use. That's how normal kidneys work. When we have kidneys that don't work normally, we still ingest the same amount of those products, but they get retained within the body because the kidney can no longer function correctly for multiple reasons. Like I said, with glomerulonephritis, this inflammation of the glomeruli within the kidney, that's the tiny capillaries in the kidney themselves. When you start having this inflammation, rather it be due by an immune response or something else, it typically follows like streptococcal infections. It could be a respiratory tract infection. It could be some kind of skin infection. We usually associate acute glomerulonephritis with something like that. So if you're going to be looking at the patient who has acute glomerulonephritis, think about what's going on with the patient. Think about, ask about changes in their urinary elimination patterns. Ask about any change in the urine color, the volume, the clarity, the odor. Think about the patient. They may describe the blood in their urine as being smoky. This is what your book says, a reddish brown, rusty, cola colored. Somewhere I was reading about ketchup colored as well. So make sure you're looking at your patient who has glomerulonephritis and think about changes like that. Hematuria, proteinuria, those are things you should start thinking about, expecting to see your patient present with. Also, daily weights, we need to make sure that we're assessing for fluid retention as well. All right. Nephrosclerosis, if you think about what the word sclerosis means, we're talking about nephrons. So nephrosclerosis is meaning that we're having benign hypertension in the actual kidney itself. So the vessels that bring blood to the actual kidney are starting to either get narrowing or some kind of buildup of plaque in there. But there's this hypertensive crisis, if you will, in the kidneys, where now you're not getting enough blood flow to the kidneys, and when you don't get enough blood flow to the kidneys, there starts to be a problem. So nephrosclerosis occurs with all types of different hypertension, atherosclerosis, diabetes mellitus. These are all precursors to somebody going into nephrosclerosis and basically leading up to kidney failure at some point. The more severe the hypertension, the greater the risk of severe kidney damage. So if you know somebody with severe hypertension, this is why we harp on it so much. It's going to kill you. It's going to make your kidneys fail at some point. And if you have kidney failure, it will lead to death at some point unless you replace your kidneys. So we know that nephrosclerosis is rarely seen when the blood pressure is below 160/110. That's straight from the book. But that's what we need to think about. Make sure your patient understands that they need to keep their blood pressure well controlled if they don't want to go into kidney failure at some point in life. So continuing on this, we'll go into something called polycystic kidney disease. When you think about polycystic kidney disease, this is a genetic disorder. It's just growth of numerous cysts within your kidneys themselves. Why is that problematic? Anytime you start growing anything inside the kidney other than healthy tissue, it's going to take the place of the healthy tissue, and you're going to have less ability to filter out the blood and impurities in the blood because your kidneys are not functioning like they should. So these cysts are typically filled with some kind of fluid. They can be very large at some point, it just kind of depends. But it results in just reduced kidney function, basically. We call this end-stage renal disease at some point because it's problematic. Hypertension, we've already kind of talked about that, the need to well control that. When I think about kidney disease and I think about polycystic kidney disease, I think about patients who experience PKD would typically experience hypertension as well. They'll have a feeling of abdominal fullness and pain. They have episodes of these cysts bleeding, so they'll have hematuria. They'll have kidney stone formations, possible to have infections and systemic diseases as well. But what I said was patients with PKD often experience hypertension. So you need to be on the lookout for signs and symptoms that your patient is experiencing maybe a hypertensive crisis. So think about if you have severe hypertension, something as simple as a headache that won't go away might be something to focus in on during your assessment because it leads you to the idea that the patient might be experiencing polycystic kidney disease. Or if you know they have PKD and they're having a headache, this could be a hypertensive crisis. So make sure you understand that. When you're trying to treat these patients, we know that pain is a huge issue, so we are going to do things to help with pain. And we will, since it's chronic pain, we'll use pain medications that are prescribed. But we know that NSAIDs and aspirin should be avoided for long-term use because of their risk of nephrotoxic side effects, something that we have to worry about as well. But make sure you're talking with your patients. Make sure that you understand, since their inability to function correctly, the fluid balance deficit, they're unable to filter like they should. So one thing that we are worried about anytime we talk about the kidneys is hyperkalemia. If the kidney's not working correctly, regardless of the cause, then the risk for them becoming hyperkalemic, meaning their potassium levels go way above where they should be, is a problem, right? So make sure you're thinking about the patient who has PKD. Think about their hypertension. Think about when we give them certain type of like ACE inhibitors for blood pressure. If you go back and you think about the renin, angiotensin 1 and 2, pumps and how that actually works on the kidney, we need to be aware that the potential for retaining potassium is huge, and that we need to think about dietary choices as well and prevent our patient from ingesting even more potassium, which would just further perpetuate the issue here. Renal vascular disease, I don't really talk about this much. It is something to think about. We're talking about the like I said, the atherosclerotic like sclerosis of the renal artery, that kind of stuff there. We really already hit on it. The risk factors for this are still high blood pressure, high cholesterol, the aging population, smoking and diabetes. You get it, heavy alcohol use. It's the same things that we talk about day in, day out. The more of these you do, the more likely you are to run into every one of the disorders we talk about in nursing school. If you really think about what we talk about, a lot of this stuff is preventable and manageable if we just did some lifestyle modification and changes. So, there you go. Kidney trauma, this is a big one. Blunt trauma accounts for most kidney injuries in the United States. It's kind of what we do. We drive fast, we fall off of stuff, but that truly is kind of what happens. I won't get into a lot, but anything that causes a kidney not to work anymore, we think about kidney trauma, it can be caused by a blunt force trauma, you could be stabbed, it could be a shot, you got a blast injury, who knows? But it leads to something called acute kidney injury. And we know that acute kidney injury can affect every other part of the body, the brain, the heart, the kidneys, the lungs. This is kind of what happens. This is when people have an acute trauma to their kidney, they oftentimes end up going to the trauma center, they end up going to the ICU because of multiple system failures. It's kind of what we're looking at there. Signs and symptoms of anybody with an acute injury to their kidney, so AKI, it just depends on what part was affected, but too little urine, so you could have not enough urine output, you could have swelling in your legs and ankles due to the retention of fluid, fatigue and tiredness, shortness of breath. You kind of get the gist here, but that's what we're talking about. All right, kind of moving right along. In the renal realm, if you will, we're going to talk about something called benign prostatic hypertrophy, BPH. Is it really part of the urinary system? Well, it can be. It's also part of the reproductive system, so it's not exactly where you think it would be. But when we think about what BPH is, it's just your prostate getting bigger than it should. Why is that problematic? Where in the man, the prostate is located on the posterior side. If you were to want to feel for it, you go up the rectum and you can feel the prostate up there. As it starts to hypertrophy, as it starts to grow and gets that hyperplasia, it starts to get big, it's going to put some pressure on the urethra itself. So men who have BPH a lot of times have urinary problems. So this is a big issue for men because you have a prostate. Like I said, as it gets big, we are really more worried about your inability to urinate on your own. So benign prostate hyperplasia affects about 50% of the men between the ages of 50 and 60, and almost 80% of men who are over the age of 80 have some kind of BPH. I worked with a urologist for years there at Walter Reed Military Medical Center in Washington, D.C. Brilliant man, and he told me that every man will end up with some kind of prostate problem. If you live long enough, you will have prostate issues. It's just the way it goes. It probably won't kill you, though. But what causes these? We know that obesity and metabolic syndrome, so obesity, glucose intolerance, diabetes, hyperlipidemia, too much cholesterol and fat in your diet, hypertension, all of these are associated with higher risk for developing BPH. So once again, it's our diet and the way we eat and not taking care of ourselves that lead to these chronic problems, more than likely. So you as a nurse, if you're taking care of a patient with BPH, think about the signs and symptoms you would expect to hear from them, especially like, the inability to start your stream. That's usually a big one. It's hard to start the stream, straining to urinate. If you've ever seen an older person with BPH, they can stand at the toilet for a long period of time, waiting for the urine to start. So that hesitancy, straining, all of those are things that are very much associated with somebody who has BPH. All right, so now that we know about BPH and what it is, we need to look at the treatments for BPH. So if you go to page 1477, there's a Cusin box that is really great. It just gives you some good insight on what you need to be thinking about as far as how to deal with these people, right? So best practices in patient safety and quality care of the patient. We're going to talk about a few things, but we know when people have BPH, one of the things they end up doing, the historical gold standard, surgery-wise for people with BPH, is something called a transurethral resection of the prostate. They call that a TURP, T-U-R-P, TURP. This is when the enlarged part of the prostate is removed. They usually do it endoscopically, so they don't have to make any large incisions, but that's what a TURP is. So why do we care about a TURP? Because you as a nurse will be caring for these patients who have a TURP. And what that means is that they're going to do continual bladder irrigation. Typically is what happens post-operatively when somebody has a TURP. They do something called continuous bladder irrigation for several days. It's a 3-way urine catheter that's used to help allow drainage of the urine, and it also allows an inflow of a bladder irrigant solution to kind of help keep the urine clear, if you will. You want to prevent any kind of clotting up in there and stuff of that nature. So what we're going to be thinking about with these patients who have undergone a TURP and now they're having this continual bladder irrigation, like I said, go back and look in your book there. It's all around page 1477. You'll see a lot of good stuff about TURP. But as you get in there and start reading about what your job is, you're going to be monitoring for infections, of course, but you need to be monitoring the urine. You need to make sure that the drainage tubing frequently is free of obstructions. There's no kinks. Make sure there are no blood clots. Make sure that the urine output is the same that's going in. Assess for bladder spasm, things of that nature. You need to be making sure, though, one of your priority things is that if they're having continual bladder irrigation, is making sure that the continual bladder irrigation is infusing and that the right amount is coming out, right? If you as a nurse start observing that there's ketchup colored drainage in the bag, you need to call the medical provider immediately. Call the healthcare provider, the doctor, let them know what's going on, because that is problematic of bleeding and issues of that nature. So we don't want that. So your book says ketchup. You can call that what you want. It's burgundy. It's rust colored. It's a thicker red, dark color that makes you look. It makes you understand that this is gross bleeding. Your book says it exactly in that Q-SIM block. Notify the surgeon immediately if the obstruction does not resolve by hand irrigation or if the urinary return looks like ketchup. That is problematic. Make sure that you're aware of what to be on the lookout for when you're helping somebody who is post-BPH TURP and has continual bladder irrigation. All right, kind of staying on the same lines as the reproductive health for patients, especially when we're thinking about men and urinary issues. We also have to think about things like testicular cancer. The most common report that people report when they have testicular cancer is this painless, hard swelling or some kind of enlargement of the testes itself. Some people do report pain, but it's typically painless. It's just a hard swelling, and you're like, it doesn't feel right. Some people have testicular pain that might be in their lymph nodes, especially if it metastasizes or moves on. There could also be a hydrocele, which is fluid in the scrotum itself, or gynecomastia, where men start having breast enlargement. This is typically more seen with metastatic diseases that has metastasized and went up the lymphatic system, but still something to think about. When you're trying to understand what you can do, you want to perform monthly self-exams. Page 1485 kind of gets into that. There is a great handout, if you will, on page 1485 that really shows you how to do a self-exam. You could print this out for your patient if you wanted to. It's the Testicular Cancer Awareness Foundation, so they can look at that. But because testicular cancer and its treatments often lead to sexual dysfunction, because once we get rid of, we'll talk about later on, the prostate, the job of the prostate is a sexual organ. It is mainly your ejaculate comes from your prostate. It's all your seminal fluids. Your testicles produce, hormones as well as your I lost my train of thought there. It's how we do reproductive health here. So your semen come from your testes themselves. So sexuality is a huge concern for these people, especially when we're thinking about the age group of 21 to 44 years of age. That is the prime time to get testicular cancer. So we really worry about the young men and their inability to perform sexually or father children. These are big concerns for guys who are going through testicular cancer. But your biggest concern is to make sure they're performing self-monthly exams, because that's what you can do to help prevent this. All right, the last thing we're going to talk about here is erectile dysfunction. And erectile dysfunction can happen for a lot of reasons. We've already talked about some of them. If you have your prostate removed, that can definitely lead to impotence and erectile dysfunction. Same thing with testicular cancer, that can do it. But more than anything, we know that a family history of things like, let's like prostate cancer. We know a family history of prostate cancer can't be changed. That's familiar. But there are certain things we can do to prevent that, of getting prostate cancer through nutritional habits. The book talks about modifying these to decrease your risk for getting prostate cancer, getting that removed, and then end up being impotent or having erectile dysfunction. We got to teach men to eat healthier. A balanced diet. Your book says this includes decreasing animal fat, e.g. red meat. Red meat has a direct link to prostate cancer and erectile dysfunction. Intake of dairy products also need to be drastically decreased. There is a direct correlation between dairy products, prostate cancer, and erectile dysfunction. Reinforce the need to increase your fruits and your vegetables, especially tomatoes, which are high in lycopene. That also has some kind of protective effect, if you will. So make sure you're talking to your patients about what they can do to prevent these, and then think about men who do have erectile dysfunction. What we typically do, your book has all kinds of documentation on what they can do to treat this. The first one's probably going to be some kind of PDE5 inhibitor. So we're talking about a medication they're going to use like Viagra, right? It's something they're going to take to help them maintain an erection. But the problem with these is there's things you have to talk to your patient about. Make sure that they abstain from alcohol before sexual intercourse because it could impair their ability to have an erection. Common side effects of these drugs include heartburn, headaches, facial flushing, stuffy nose, things like that. You need to make sure you talk to men that if they're taking nitrates to avoid taking the PDE5 inhibitors because of the vasodilation effects. This can cause profound hypotension. Once again, if you have to be on a nitrate because you're having some issues with heart, coronary artery blockage, having sex probably not for you anymore. So think about lifestyle changes. A patient with erectile dysfunction typically has that because there's a deeper cardiovascular issue. And if you want to prevent that, especially in men, you need to think about diet. So big things for you to think about. Make sure you're talking to your patient about, if they are going to take like Viagra, you should plan on having sex within an hour after taking your medication. Make sure you take like one pill a day. Don't overdo it. Make sure you talk about the side effects, especially with the hypotensive issues there and safety problems. That's where you're going to focus your attention. All right, that's all I have to say about that. If you have any questions, please let me know.